Thank you, Debbie. I'm going to try to speak more out of my professor of public health persona than my faith in health persona this morning. But I'm primarily speaking on behalf of the Health Systems Learning Group, the stakeholder health group that Kevin alerted to earlier. Stakeholder health is a group of approximately 40 mission-driven healthcare systems that understand their mission to include public health improvement. For the past 2 years, senior staff from a number of those systems have focused on the attention on the question of whether we can actually succeed in that mission in the context of a policy framework that is still very much under construction. And in fact, in many of the states in which we work, it's being actively contested and in our case, actively sabotaged. Our interest is not focused on whether we can meet the legal requirements of community benefit. I appreciated Kevin's distinction between compliance and transformation. All of our participating health systems are in compliance, but not satisfied at all with what those funds, almost entirely spent on emergency room care, are achieving. So we formed a peer learning group to see if we could do much better. The monograph that emerged from this learning benefited greatly from a close working relationship with the White House and HHS offices of faith-based and neighborhood partnerships, as well as expert assistance from Kevin and associates from the Carter Center. These findings and a constantly renewed stream of models and other stories that are putting flesh on the bones of logic are at stakeholderhealth.org, and I commend that to you. Now, for purposes of this roundtable, we want to focus on the funding implications of our findings. The business case for proactive engagement with the neighborhoods most vulnerable to health challenges is simple. The largest single line item in almost any not-for-profit health system is charity care. The only competing line is bad debt now, resulting from high uncollectible copays common in the new bronze insurance plans. I'll save for later the discussion that David raised about the issue of Medicaid reimbursements as part of charity care, but there's enormous complexity in there. Now, the point I would want to make is that those two lines are unmanageable once the people on the streets cross the sidewalk and become patients. Hospital doors are open 24 hours a day. So the only place for us to engage these most fundamental challenges that are financial business case challenges is on the other side of the sidewalk. The stakeholder health ensemble suggests that it is possible to do a different way, to engage on the other side of the sidewalk, but it demands an entirely new set of competencies and practices that are quite unusual for healthcare systems. Now, healthcare systems do have unique and uniquely timely data on the most vulnerable patients that allows us, if we choose to know, important to say, if we choose to know, a great deal, not only in real time, but predictively, since in most cases the care offered is only a landmark on a longer journey of health that is quite analyzable all by itself. And that journey has patterns, both for individual patients, but most importantly, as Kevin underlined, about the places where those most vulnerable patients reside. Among the stakeholder thought leaders, Dignity Health and Loma Linda University Health helped us see the power of blending utilization and social determinants data made visible on maps to drive investment and deployment of healthcare assets along with partnerships that are carefully crafted along those maps. Yet none of us believes that the state of that art is close to what technology and the arts of partnership suggest is possible. A very specific recommendation is for the next iteration of, quote, meaningful use to focus on this area of practice. The stakeholder health insight is that it is both possible for private healthcare systems to be significant partners in transformation of health of their communities through embracing what we called an ensemble of practices that is quite straightforward and logical, but is going over the bar backwards, hence the slide. First, move towards the most socially complex people who from time to time are patients in their socially complex neighborhoods, place-based focus. Secondly, do so in large-scale partnerships that are focused on place-based tactics, prioritizing the most vulnerable neighborhoods. And thirdly, spend our own money proactively instead of reactively, as is currently the overwhelming reality. It's important to say, when we talk about charity care and emergency room care, that it is always right to provide mercy and care to someone in pain, distress, or burdened by disease, even though it might be logically obvious that it would be better for those people to have received that care earlier and at some other point of service. What we are learning is that it is always wrong to ignore the pattern of the needs and the places of those patients. It is obvious, even maybe especially to our chief financial officers, that proactive mercy would be more decent and in fact cheaper, way cheaper, than reactive charity. But the reality is that the vast majority of community benefit funds are currently frozen quite solidly in reactive paradigms. For purposes of reporting, charity care and bad debt are different accounts. They show up in different places in the financial accounts. But the human point of reality is that the emergency room and that those at that place where the care is provided, they are indistinguishable. The funds are not easily made fungible, unfrozen, by simply reallocating them to community health, much less imagining that someone's going to write checks for this to some sort of a community mechanism, when in fact the funds are locked and frozen in a point of care right now. Most of the reactive cost experienced in the emergency room provided to those unable to pay are fixed costs, or those expenses such as staffing that are not sensitive to incremental changes in utilization. It's important to note and not excuse the radical and abundant perversity of healthcare marketing and reimbursement in which we work. In the context of charity care, the most obvious is that most hospitals, including my own, focus a good bit of marketing to attract paying patients to the emergency room, which are profitable for the insured and are a key on-ramp to the even more profitable inpatient, let us call them hotel services. Of course, the and poorly insured read the same billboards, exacerbating the market share of charity care as well. Now, stakeholder health suggests that healthcare systems can be important partners in community health despite this perversity if senior leadership, especially the boards, understand the possibilities and the relative costs. The key is that ER-based charity care is extraordinarily costly compared to the proactive place-based tactics. Anything on the streets is pennies compared to the dollars inside the walls. But communities are very large places and consume a great many pennies if they are not highly focused in our efforts. Hospital data offers extraordinary potential for focusing partnerships on the neighborhoods and even streets where the charity care lives predictably and consistently. While it is difficult to predict exactly which human being will present for care on any given day, it is highly predictive the streets from which they will come. Hospital data can be GIS mapped in real time to guide those proactive strategies with great precision, which can then focus the ensemble of practices towards the specific kinds of social complexity to engage with exactly which kind of relevant partners. More importantly, the partners with non-hospital intelligence can see the dynamics driving the behavior of patients and providers in new ways. That blended intelligence, achieved through highly participatory partnerships, creates powerful feedback loops, building trust and aligning networks. Now, I want to caution us that the language of social determinants can be a conceptual trap, especially as it makes us think of them in very long-term and indirect strategies. We're interested not just in the vagueness of social determinants, but in the array of bio, psychosocial, and spiritual determinants of health over a lifetime, especially as the works of mercy, proximate care, can be part of the process of building webs of trust in partnerships and social networks. Some of the most fundamental determinants of health, food, housing, warmth, cooling, safety, education, are engaged by many of the identical community partnerships the healthcare systems are moving towards most logically to engage what we think of as proximate healthcare challenges. ProMedica Health is distinctive among our stakeholder health partners in its focus on what most would regard as one of the most intractable challenges, food and hunger. Yet they have helped us see that even there's an enormous amount that can be done at scale and at speed. The opening slide suggests a number of practical applications for the logic and how the lessons from Memphis and the larger stakeholder group are being adapted into our own North Carolina communities under the name of Faith Health NC. When we analyzed the Memphis model data, which Dr. Cutts will unpack in just a moment, we learned that the congregational-based partnerships, which are highly variable, 500 highly variable congregations in every possible way, those partnerships move the data quite significantly. The complex networks accomplish this not by embedding hospital methods or even public health methods in the congregations, but by blending the intelligence of the congregations about the journey of life of their own members and neighbors with the intelligence of the medical professionals about the disease and injury conditions experienced along that journey. The more complex and chronic the conditions and long-term cost implications, the more the blend of intelligence is needed. But at a very basic level, the congregational networks seem to be making it more likely that patients from their networks showed up at the right door, at the right time, ready to be treated, and not alone. That's what saved the cost. Perhaps the most counterintuitive is the invitational, not restrictive logic driving the phenomenon. Our experience indicates that when the most vulnerable are invited, I underline the word invited, through networks of trusted relationships, they're more likely to accept the invitation at a more logical time, which usually means lower acuity and therefore lower cost. Logically, this would pertain regardless of payer, but it is certainly in the profound interest of the healthcare system to extend this invitation in ways likely to be accepted by those least likely to pay. When that happens at large scale over time, it affects the cost and quality of the patient experience, of course. Numbers of patient encounters may increase, as we saw in data, but the cost of those encounters decreases. That's where the cost is saved, not by restricting access, but actually by inviting access at earlier stages when it's likely to be useful. This is accomplished by highly variable social complexity of the congregational networks and go way beyond what the hospital would be able to instruct them to do, or the public health department could instruct them to do. The intelligence rests in the congregation, not in either of our healthcare specialists. Not that we don't try to instruct. Thousands of members receive training that they felt like was quite relevant. But it is the web of trust among the partners invested in through the Congregational Health Network that has resulted in the effect. Now, one of the accomplishments is lowering the cost of charity care, just as it also lowered the cost of Medicare in the broader cohort of CHN patients in years. This is the key finding from stakeholder health. An ensemble of practices sustained in long-term sustained partnerships built on trust, focused on mercy and justice, can improve access and thereby lower overall cost of care in vulnerable neighborhoods. This is not something that can be done to community, but with community. It demands healthcare systems and their public health partners to go over the bar backwards, unlike the way they have been used to going over for many decades, which is, I suggest, as David would suggest, why the map never seems to change. Perhaps the most demanding of all parts of this phenomenon are what we would call the arts of humility, required for working partnerships which have intelligence about the communities where the greatest challenges reside. In North Carolina, we were surprised by the most obvious thing. Many of our own hospital employees live in the most vulnerable communities. 48% of our environmental workers live in the zip codes where 49% of our charity care is concentrated. Thus, we came to understand that we must cross-train some of our own employees as community health workers, which they have named themselves as supporters of health. We anticipate in the most critical census tracts we will see, as we did in Memphis, an increase in low acuity care and a decrease in high acuity demands. These neighborhoods, not surprisingly, are also the highest priority for our local public health department with whom we do joint training. Healthcare systems are critical partners with public and other social agencies engaging the social determinants of health. They are not best understood as funders of others' work, but mission-driven organizations that have good reason to be better partners.
Thanks, Gary. Like usual, Gary's brilliant ideas are always footnoted with data. And so I'm very quickly, at the end of our time together, going to share with you a little bit of data from still the Memphis case. I just left there about 3 months ago in terms of how we were able to turn the needle on charity care in one of our toughest neighborhoods. This is I don't have time to go into the details of what we did, but it was a population health-based, place-based population health strategy we call Wellness Without Walls. We started late in 2011, and we used the hotspotting method that was made famous by Jeff Brenner in Camden. And we found that for 2010, which was our baseline data, of course, most of our charity care was concentrated in a few zip codes, but the top one was 38109, which of course is where most of the poverty is concentrated in Memphis. And even there, it was actually a little bit farther pinpointed in an even hotter neighborhood called Riverview, Kansas, where we concentrated our efforts in terms of the place-based population health management. What we also discovered, though, was that those resources that were talked about today were the congregations. And you can see, and we call this laughingly the amoeba map, right? That many of our congregations and our highly engaged congregations were in the areas where most of that charity care was concentrated. And so we took from that a strategy that involved community engagement, which started with our CEO, Gary Shorb, actually coming to ground for a community tour in Riverview, Kansas. Listening, developing programs. We actually brought in Cigna as a stakeholder partner, and they gave us a community grant to actually do some work in that area. And then, of course, we did traditional hotspotting, and I laughingly call this the participatory hotspotting dashboard, because it was a combination of our business and strategic development folks putting together their brains and looking at clinical data, along with our navigators and the folks in the congregation, in terms of what were the resources out there. And not only what were the numbers in terms of these folks that were super utilizers bouncing back in the hospital, but what was the story behind them, and how did we engage the assets in the community to help? Particularly the Healing Center, which is a African-American triage system to get people into behavioral health in the African-American communities and through the churches. But this was the data. This is what happened and we started in 2012. So you can see charity care visits actually went up in 2011. They came down a bit in 2012. I put total visits here because you can see our visits continued to increase and climb. At Methodist, you can see, though, that our actual charity care cost, jumped up from 2010 to 11, but once we began to implement our programming in 2012, it dropped down, not only for all patients, but for that specific 38109 residency area. These are the specific data points in terms of visits, full cost, variable cost, and average per capita charity cost. But look down at the bottom of the right side, and you can see that from 2010 to 11, when we weren't implementing programming, we had a huge jump in terms of charity care. But from 2011 to 12, we had a drop of almost 7%, and that's all patients. In our specific targeted zip code, we had the same sort of trend with even more dramatic differences in terms of charity care decrease, almost 9% in 2012 in that target hotspot zip code. Our CFO, Chris McLean, is much more conservative, and he said, well, I've got a better way of doing this. And he wanted to actually look at transactions instead of discharge data. We were looking at actual individuals that came through, looking at admin discharge data. And he said, let's be conservative, and he created a cost to charge ratio, the cost of actually providing services to the charge that was actually put forth to that individual for transactions. A lot of our folks come in through the ED, bounce to inpatient. And even with his conservative kind of mechanism here, you can see we had a drop from 2010 from 25% down to 23.15%. And this was the first and second quarter of 2013. So we had at least flattened the curve, even by his very conservative metrics. And I think we're about ready to wrap up, Debbie. So is it good? One more minute. Okay. The place-based population health management strategy that we used was to actually engage one of our navigators who was part of the CHN to actually be on the ground. Most of the navigators we had prior to this were actually based at the hospitals and were kind of keyed to geographic areas but not specific neighborhoods. And her job was to actually navigate folks from health events. We don't use the word health fair because it's not episodic, but to have some continuity of care. So every 2 months we would have a health event. She would personally follow the individuals to get them to primary medical homes, try to navigate them to the safety nets that were already existing, or to social service agencies. And we found that's been very, very useful because, quite frankly, a lot of our folks really, because of the trust issues and distrust issues, don't even use the existing safety net clinics and other resources that are out there. So, thanks. Mm-hmm.